Hello there and welcome everyone to today's webinar. My name is Winnie Sibilak and I am the Senior Marketing Manager here at Draeger. Well, it is truly my pleasure to introduce today's speaker, Dr. Ewan Goligher. Dr. Goligher is the Assistant Professor of Medicine and Physiology at the University of Toronto and a clinician-scientist at the University Health Network. His program of research is aimed at developing and testing lung and diaphragm protective strategies for patients with acute respiratory failure.
Okay, so I've been invited to present on the issue of ventilator-induced diaphragm dysfunction. Hopefully by the end of the presentation and our interaction together, I'll have persuaded you that this is really an important issue in our patients and that there may be things that we can do about it. These are disclosures. In particular, I'd note conflicts of financial interests related to a number of companies doing phrenic nerve stimulation and mechanical ventilation. So the objectives of our time together, first of all, to appreciate the impact that diaphragm weakness has on the outcomes for critically ill patients. Secondly, to review the mechanisms by which ventilator-induced diaphragm dysfunction evolves. And thirdly, just very briefly, we'll survey some potential approaches to preventing injury of the diaphragm related to mechanical ventilation. So we're all quite familiar with the concept of weaning from ventilation, and it's a fairly stereotypical process that proceeds through the acute phase where the patient's relatively more sick and acutely ill. And then once their initial insult begins to recover and they progress into the readiness to wean phase, and they enter the weaning phase, patients can be divided into three groups. There are patients for whom weaning is simple and straightforward and who rapidly weaned off ventilation. There are other patients for whom weaning proves more difficult and they have at least two or three repeated attempts at weaning before they're liberated from the ventilator. And then there are some patients for whom weaning proves very difficult and they require prolonged weaning. And importantly, the outcomes of mechanical ventilation are very different between these groups. So patients who are readily weaned have a relatively low mortality. Patients who have difficult weaning have an intermediate mortality, and then patients in whom weaning proves difficult or prolonged rather have a very high mortality. And of course, to some extent, this reflects the underlying severity of illness, but also reflects the fact that the more time you spend on the ventilator, the higher you are at risk for nosocomial complications that impact your long-term outcome in important ways. One of the important things to understand is that really requiring prolonged mechanical ventilation and having prolonged weaning is really a devastating life event. And these are older data now, but nevertheless still highly applicable, showing that patients who require prolonged mechanical ventilation, which was defined in this study as 21 days, most of those patients were alive with either complete or some functional dependency, and many of these patients progressed to worsening functional dependency over the ensuing year. So patients who require prolonged mechanical ventilation generally wind up with significant disability. And so it's really important priority to try and avoid prolonged ventilation if possible. Data from the Lancet published about 8 years ago show that of patients who require prolonged mechanical ventilation, which they define as 14 days on the ventilator, only 20% are discharged home and about 60% are dead within a year. So again, this problem of prolonged ventilation is important for long-term patient-centered outcomes. So the question is, why do patients get stuck on the ventilator? Why is it that some patients enter the weaning phase and are readily liberated and others struggle to get off the ventilator? And this really has to do with the issue of imbalance between respiratory system capacity and respiratory system demand. And I think this figure here from an older review by Neil McIntyre nicely illustrates the challenge that we have this balance between the loads placed on the system related to deranged mechanics, say impaired compliance or increased resistance, and increased ventilation loads related to dead space and VCO2. All of those things increase the work that the respiratory system has to do. And the system can only tolerate those increases in work if it has the capacity to respond to those loads. And that's principally and critically determined by respiratory muscle function. So if patients have respiratory muscle weakness at baseline or develop respiratory muscle weakness, that may have a profound impact on their ability to be weaned from the ventilator. Just by way of background to give you a feel for just how we go about assessing the function of the diaphragm, which is the principal muscle of respiration. This is a picture showing the measurement of twitch transdiaphragmatic pressure using a magnet applied over the phrenic nerve. What you can see is that when the stimulator fires, that activates the phrenic nerve to make the diaphragm contract. And you'll see here that there's a dip in esophageal pressure, while at the same time there's a rise in gastric pressure. And the mathematical difference between these two gives you the transdiaphragmatic pressure, and that reflects the pressure generated by the diaphragm's contraction. Another technique for assessing the function of the diaphragm is ultrasound, which has proven to be extremely both simple and very useful. So here you can see, using a linear array probe placed over the right hemithorax at the anterior axillary line, that you can delineate the pleural line, the peritoneal line, and the diaphragm in between. And that enables measurement of the thickness of the diaphragm muscle. Now, when the diaphragm is contracting, it functions very much like a piston in a cylinder, and I find this figure here useful to visualize what's happening with the diaphragm. So it's a dome-shaped muscle, but primarily when it contracts, what changes is not so much the configuration or shape of the muscle, but rather the length in the zone of apposition. So you can see these points here, which represents the costophrenic angle, how the point as the muscle contracts, as seen on MRI, you can see the zone of apposition progressively shortening. And so really what you visualize with the ultrasound is the shortening and hence the thickening of the muscle during inspiration. And it's been shown that the thickness of the muscle as a percentage of expiratory thickness increases in proportion to inspired volume. So the ultrasound is a very useful technique to visualize the thickening of the muscle. And so if you visualize the muscle with the ultrasound, and you can pick out the pleural and peritoneal lines here, you can see that as the patient makes an inspiratory effort, the muscle thickens, and you can use that thickening of the muscle to assess its contractility or the level of inspiratory effort by the patient. Now, the utility of this is that it gives you a way of assessing whether the diaphragm can contract, and hence a way of assessing the function of the diaphragm. So for example, in a classic paper looking at patients with hemidiaphragmatic paralysis, you can see here the thickening of the diaphragm during inspiration is 0 or even a negative value, reflecting that the paralyzed side is getting stretched. While on the non-paralyzed side, the functioning side, the thickening of the diaphragm is intact, and you can see a substantial increase in thickness during inspiration to total lung capacity. And thickening of the muscle is also correlated to maximum inspiratory pressure. So I'm just making the case here that these ultrasound measurements are a useful way of seeing what the muscle is capable of. And throughout this talk, I'll be referring to these twitch pressure measurements and these ultrasound measurements. And so you have some feel for what is being described. So Alex DeMoule and colleagues looked at the incidence of diaphragm dysfunction within 24 hours of intubation. And they did so using the magnetic twitch stimulation technique, which is a very useful technique because it avoids the need for any patient inspiratory effort. You basically have a standardized twitch stimulus to the muscle, and you can assess the muscle's force generating capacity with the pressure on the airway that I indicated. And what they found was that, as you can see here, compared to controls, healthy controls, this is the range of twitch tracheal stimulation pressure, anywhere between 15 to 37 centimeters of water. Many patients had significantly reduced twitch tracheal stimulation pressure, less than 10 centimeters of water. And importantly, patients who had sepsis or a higher SAPS-2 score indicating higher severity of illness were more likely to have diaphragm dysfunction. And interestingly, these patients here with diaphragm dysfunction at baseline were more likely to have were more likely to die than patients without diaphragm dysfunction, but not necessarily more likely to have prolonged mechanical ventilation or length of stay in the ICU. So this suggests that very early diaphragm dysfunction is a kind of another marker of organ dysfunction and reflects the severity of illness and the risk of death. Later diaphragm dysfunction is incredibly common. So here are multiple studies looking at twitch transdiaphragmatic pressure in patients who've been mechanically ventilated for at least a few days. And you'll see that the normal twitch transdiaphragmatic pressure is approximately 28 to 30 centimeters of water. That's the sort of expected value in healthy adults. And in multiple studies of critically ill patients, you'll see that twitch transdiaphragmatic pressure comes in far below that. So this appears to be extremely common to have reduced diaphragm force generating capacity in critically ill patients of varying duration of mechanical ventilation. So the question is, why? Why is diaphragm weakness so common in these patients? And in truth, there's a whole range of factors that give rise to acute muscle dysfunction and acute diaphragm dysfunction in particular. So sepsis and the metabolic and mitochondrial dysfunction that accompany systemic inflammation clearly contribute to diaphragm injury and dysfunction. Shock states, reduced organ perfusion, certain medications such as steroids and aminoglycosides can cause acute muscle weakness. And then, of course, the well-described phenomenon of critical illness neuromyopathy, which affects not only the peripheral limb muscles, but also the respiratory muscles and the diaphragm. But importantly for our purposes, what's troubling and very concerning is that the ventilator itself, there's now a growing body of evidence suggesting that the ventilator itself can contribute to diaphragm injury. And this observation gave rise to the concept of ventilator-induced diaphragm dysfunction. And what that also means is that potentially, if we understand the mechanisms by which the ventilator causes diaphragm dysfunction, we can also potentially modify the application of ventilation to prevent diaphragm injury and dysfunction, and perhaps avoid some of this weakness and accelerate liberation and recovery and avoid long-term disability. So this becomes the priority, and I want to now briefly survey some of the mechanisms by which mechanical ventilation leads to diaphragm dysfunction. So the first mechanism, and perhaps the most important, is disuse atrophy. And experimental studies, and now some human data that I'll show as well, have convincingly demonstrated that even a short period of diaphragm inactivity is associated with a progressive loss of diaphragm muscle mass and muscular force generating capacity. And this is demonstrated in this classic experiment from Scott Powers and colleagues, who demonstrated that if an animal is intubated and sedated but kept spontaneously breathing, that there's no decrement in force generating capacity over a 24-hour period, as evidenced on the force frequency curve here. So what you have here on the y-axis is the force generated by the diaphragm in response to stimulation, and you have progressive increased stimulation frequency, which generates progressively greater pressures until you reach what is called supramaximality. And supramaximality is basically the way of demonstrating that reductions in force are not related to inadequate stimulation. And you can see here on the right that you achieve supramaximality, but at supramaximal levels of stimulation, the diaphragm force generating capacity progressively decreases over time from 12 to 8 and 18 down to 24 hours. And so this suggests that that ventilation itself is associated with a direct injury and impairment of diaphragm function. This issue of atrophy was elegantly demonstrated in brain dead organ donors, where they showed that in comparison to patients undergoing thoracic surgery for just a few hours, the myofibrillar cross-sectional area of patients diagnosed with brain death was markedly reduced, and markedly reduced. And strikingly, if you look at this plot on the right here, you'll see that there's no difference between cases and controls in a chest wall muscle, the pectoralis major. So this is a diaphragm-specific acute atrophy occurring within 18 to 9 hours of the diagnosis of brain death. So a rapid onset diaphragm atrophy specific to the diaphragm muscle that sort of corroborates or fulfills the expectations suggested by previous experimental work. So it's clear that the diaphragm basically begins to melt away once it's rendered inactive under mechanical ventilation. Now, the molecular biology underlying this process is complex. And the exact mechanism linking inactivity to atrophy is actually still not precisely delineated. But what's clear is that in a muscle that's rendered inactive, there's a buildup of reactive oxygen species and associated with an abnormal metabolic state. And that leads to the activation of various proteolytic pathways that rapidly degrade the muscle, as well as mitochondrial fission and lysosomal degradation. So mitochondria actually are absorbed and destroyed. And of course, that also undermines the function of the muscle. And a range of experiments suggest that targeting these reactive oxygen species or promoting mitochondrial function might actually avoid diaphragm atrophy and dysfunction, but that remains to be tested. So how common is diaphragm atrophy? How big of a problem is this really? Well, some of the best clinical data we have to date suggests that it's really quite common. And in our cohort study, we found that about 45% of patients had a rapid early decline in diaphragm thickness over time. So this seems to be a relatively common problem during unselected patients with hypoxemic respiratory failure, and definitely warrants our attention and concern as we manage the ventilator. Now, critically, even in patients, what seems to be the main determinant of the rate of change in diaphragm thickness or loss of muscle mass over time is the daily diaphragm electrical activity or daily diaphragm thickening fraction on ultrasound. So measures that reflect how much the muscle is actually being used predict the rate of change in diaphragm thickness. So you can see here that when activity levels are very low with either measurement, that's associated with progressive loss of muscle thickness over time. Whereas if activity is higher, that's associated with a relative increase in diaphragm thickness over time. For various reasons I'll talk about momentarily, we hypothesize that that may be load-induced injury and inflammation, that increase in thickness. It's certainly not physiological hypertrophy from excess use. And interestingly, we see that while there's some association between mode or applied pressure on the ventilator and the rate of diaphragm atrophy, even in partially assisted modes like pressure support, there's still a progressive loss of diaphragm thickness over time. And that seems to be related to the way the pressure support is set. So when pressure support is set with relatively high inspiratory pressures, the rate of loss of diaphragm thickness per day is higher or more negative than if there's a relatively lower inspiratory pressure. So these data suggest that even in pressure support, if we over-assist patients with excessive levels of pressure support, we can still suppress inspiratory effort to the point that disuse atrophy may develop. Now, there's a second suspected mechanism by which diaphragm injury and dysfunction develop during ventilation, and that is excess loading or load-induced diaphragm injury. And this has been demonstrated in an experiment published now over 2 decades ago that looked at the diaphragm biopsy specimens after inspiratory threshold loading immediately prior to lung transplantation and thoracic surgery. And on the y-axis here, we have diaphragm injury quantified in terms of the number of sarcomere disruptions on microscopy. And what you can see is that inspiratory loading in both the controls and in COPD patients is associated with an increase in diaphragm injury. And strikingly, the COPD patients who have a chronically elevated respiratory load have a higher level of diaphragm injury than the controls. So excess loading of the diaphragm, both acutely and chronically, is associated with an increase in diaphragm injury. It's also been demonstrated that acute loading of the diaphragm is associated with acute injury and inflammation of the muscle. So here you can see normal muscle architecture, and here you see a following application of acute inspiratory loading, this dense inflammatory infiltrate in the muscle. So this is this is indicative of acute inflammation within the muscle as a consequence of inspiratory loading. And this acute inflammation will develop over a period of several hours following the cessation of excess loading. And quite strikingly, these features of load-induced injury have been demonstrated in mechanically ventilated patients. So if you look closely at this microscopy of diaphragm muscle architecture in a patient who'd been under mechanical ventilation for a relatively short period of time versus a patient who'd been on mechanical ventilation for a longer period of time, you see significant disruption of the architecture, and on electron microscopy, you can see sort of rupture of the sarcolemma, inflammatory infiltration there. So, and if you look at sarcomeric injury score, long-term mechanical ventilation, meaning more than a few days, is associated with a much higher level of injury. And in fact, there's a direct correlation between duration of ventilation and the degree of sarcomeric injury. So there seems to be an association between exposure to mechanical ventilation and features of load-induced diaphragm injury that likely contribute to diaphragm dysfunction. And what's so interesting is that there are some experimental data that suggest that in direct opposition to the concern that ventilation promotes diaphragm atrophy, it's possible that ventilatory support could actually protect the diaphragm from load-induced injury. So in this experiment, where rats were subjected to 3 conditions: control condition, lipopolysaccharide plus mechanical ventilation, or lipopolysaccharide alone, and then they were sacrificed to evaluate diaphragm fiber structure and function. And what you can see is that, as expected, the controls have very low levels of membrane damage. The animals subjected to LPS, which basically mimics sepsis and systemic inflammation, have very high levels of diaphragm membrane damage, and then mechanical ventilation actually prevents that damage from occurring. So sepsis and systemic inflammation seem to render the muscle membrane fragile and vulnerable to injury. And here you can see on the right that this has important functional consequences. So the worst degree of dysfunction is in the animals with LPS alone, and mechanical ventilation is actually somewhat protective by comparison. So this sort of reinforces the idea that under assistance from the ventilator may actually cause diaphragm myotrauma as much as over assistance. And there is some circumstantial evidence to suggest that this actually does occur in the clinical setting. And you'll remember in this figure that I showed earlier here, there's this rapid early increase in diaphragm thickness over time. And this occurred in a minority of patients. And when we first saw this, we were a bit perplexed. What does this actually mean in terms of what's going on inside the muscle? Because it's certainly too short a time course for diaphragm hypertrophy or increase in diaphragm muscle bulk. But interestingly, we noted this ultrasound study here where subjects who had ultrasound measures done on day after exposure to a biceps loading condition had a progressive rise in muscle thickness on ultrasound, reflective of muscle swelling. So maybe that patients who have a very high level of respiratory effort and then get put on the ventilator and continue to have excess loading will actually develop muscle swelling and an increase in thickness, reflective of possible edema and inflammation. And strikingly, in this outcome study that I'll tell you a bit more about, we found that an increase in diaphragm thickness was actually associated with a higher rate of diaphragm dysfunction in comparison to patients without any change in diaphragm thickness. So both decreases and increases in thickness appeared to be associated with an increased rate of diaphragmatic weakness. Now, a third mechanism, and again related to load-induced injury, are what I would call eccentric contractions. So eccentric contractions are contractions that involve activation of the muscle while it's lengthening, as opposed to concentric contractions, which involve activation of the muscle while it's shortening. And we're familiar with eccentric loading from being on the ski slope, and you can see here that as the skier goes into the turn, they're flexing their knees and lowering their back down. But in order to prevent themselves from falling completely backward, they're at the same, even while they're flexing their knees, they're activating their quads to keep from falling backwards. So the quads are actually being lengthened because of knee flexion, while at the same time they're actually contracting to avoid falling completely backward. And eccentric contractions are much more injurious than concentric contractions. And this is why after the first day of skiing in the season, we're so sore and stiff because we've been applying an eccentric load to our quadriceps all day long. And importantly, the diaphragm actually can be subjected to eccentric loading conditions as well. So if you imagine the diaphragm contracting as the dome descends, well, that's a typical concentric contraction. But if there are conditions under which the diaphragm is actually being forced to lengthen and the dome is ascending while it contracts, that actually gives rise to eccentric loading conditions. And in this experiment, it was shown that an acute, short bout of eccentric contractions was associated with a rapid decrease in twitch gastric pressure, reflecting a loss of ability of the muscle to generate force following exposure to eccentric contraction. So these kinds of loading conditions may be acutely injurious to the muscle and may lead to significant muscle weakness potentially. There is some data to suggest that this may be important and that eccentric loading is a real phenomenon. So, during spontaneous breathing with diaphragmatic contraction, there's a significant reduction in atelectasis during spontaneous breathing in comparison to passive mechanical ventilation. But importantly, the way that the diaphragm prevents atelectasis from developing is by decelerating its contractile activity more slowly. So if you look at during the period of the expiratory phase, the transdiaphragmatic pressure is actually higher throughout than it is when the diaphragm is just relaxing, following peak inspiratory effort. And so you see here eccentric loading conditions. The diaphragm is maintaining activity even as lung volume is falling, just to prevent lung atelectasis or lung volume dropping too much. This is what's called expiratory braking. And just as an example of a waveform, here you have a patient with apparent reverse triggering. The diaphragm is activated following the onset of ventilator-delivered flow and pressure. You can see the onset of the inspiratory effort here, the diaphragm electrical activity here. And then the patient's effort continues throughout the breath, even after the ventilator cycles into expiration. So here you see flow cycling into negative, indicating expiratory flow, but the continued action of the diaphragm here is breaking it or slowing it down. So this implies that the diaphragm is actually being eccentrically loaded. So reverse triggering may cause acute diaphragm dysfunction. And in fact, Felipe Damiani and colleagues demonstrated that when the reverse triggering contractions were vigorous, that appeared to be associated with diaphragm weakness. So just how important of a problem is this in terms of clinical outcome? What impact does diaphragm dysfunction have on outcome? Well, this paper from Marta and Dress showed that if you look at the outcome of difficult weaning, for example, the blue bar here, patients with diaphragm dysfunction have nearly 50% chance of having difficult weaning, whereas patients without diaphragm dysfunction have a less than 10% chance. And that's a much bigger difference, presence or absence of diaphragm dysfunction, in comparison to the presence or absence of limb muscle weakness. And similarly, prolonged weaning or the risk of death, very different between the presence or absence of diaphragm dysfunction and less different depending on the presence or absence of limb muscle weakness. So what's important to appreciate is that ventilator-induced diaphragm dysfunction and diaphragm weakness is not perfectly correlated to limb muscle weakness, and that weaning outcomes are much more affected by diaphragm dysfunction than they are by limb muscle dysfunction. Similarly, patients with diaphragm dysfunction measured in ultrasound, here shown in the orange bars, have a higher time on ventilator, a more prolonged time on weaning, and a more prolonged ICU and hospital length of stay in comparison to patients without diaphragm dysfunction. We've also shown that the change in diaphragm thickness is associated with impaired liberation from the ventilator. So here on the x-axis, you have the change in diaphragm thickness from baseline. And you'll see that both decreases from baseline and increases in baseline are associated with a lower relative probability of being liberated from the ventilator on any given day. So this loss of diaphragm muscle mass or this increase in thickness suggestive of possible injury seem to be predictive of more prolonged ventilation. And similarly, we found that both increases in diaphragm thickness are associated with delayed liberation from the ventilator. So here you see patients with no change in diaphragm thickness during the early course of ventilation are more rapidly liberated from the ventilator, whereas patients with early changes in diaphragm thickness have a lower probability of being liberated from the ventilator by day 21. Similarly, both decreases and increases in thickness relative to baseline were associated with more prolonged ICU stay and a higher rate of at least one complication of respiratory failure, where the complications here is a composite of death, reintubation, tracheostomy, or prolonged mechanical ventilation. And so, yeah, this highlights the fact that these patients are at considerable risk of a worse outcome if they develop these deleterious changes in diaphragm thickness. So if it's the case, as I already showed this figure, that an intermediate level of effort measured either by ultrasound or diaphragm electrical activity or however you think, however you're measuring respiratory effort, if an intermediate level of effort is best, then those patients with an intermediate level of effort should have the best outcome, the shortest duration of ventilation. And that's exactly what we found. If we look at patients distributed according to the average diaphragm thickening over the first 3 days of ventilation, we found that patients with this intermediate level of thickening fraction have a shorter duration of ventilation compared to patients with either relatively low effort or very high effort. And this gives us a potential target to think about when we're applying mechanical ventilation. Can we adjust ventilator support and sedation to achieve optimal levels of respiratory effort? That's really become the important question in our field. So based on all the data I've shown, this led us to hypothesize this, what we call the myotrauma pathway or diaphragm myotrauma pathway. So just like we have volutrauma and biotrauma, well, we're talking about myotrauma of ventilation-related diaphragm injury. The idea is that adversely applied mechanical ventilation leads to derangements in inspiratory effort, either excessive or insufficient effort, which then leads to diaphragm atrophy and injury, which then leads to prolonged ventilator dependence. And when we tested this pathway using mediation analysis, we found that the inspiratory effort was an effective mediator of the association between ventilator settings and diaphragm injury, and the changes in the diaphragm and ultrasound were a significant mediator of the association between inspiratory effort and prolonged ventilator dependence. So these mediation analyses corroborate, they don't finally confirm, but they corroborate the existence of this pathway and suggest if we can intervene up front to optimize ventilation and optimize respiratory effort, then potentially we can improve outcomes for patients. Now, of course, the big challenge to doing this, to getting the diaphragm active, is to make sure that while we're protecting the diaphragm from diaphragm activity, we don't actually end up injuring the lung. And the potential for lung injury is now from diaphragm activity is now recognized as patient self-inflicted lung injury. The idea being that you're not only distending the lung with positive pressure from the ventilator inside the lung, you're also distending the lung with negative pressure generated by the contraction of the diaphragm. And if those diaphragmatic contractions are vigorous, then the lung distending pressures can be very high. So this needs to be monitored, considered, taken into account when applying mechanical ventilation. So just briefly to wrap up, what are some future directions? Where do we see the field moving to address this problem of ventilator-induced diaphragm dysfunction? Well, one concept that we've been working on is the idea of lung and diaphragm protective ventilation that integrates our conventional lung protective approach with a diaphragm protective approach. So we're converting ventilation from a two-dimensional problem into a three-dimensional problem. So whereas, conventional lung protective ventilation, we adjust the ventilator to ensure an adequate blood gas, adequate ventilation, while also ensuring that the tidal volume and plateau pressure are not excessive. Well, now we're adding a third dimension, which is respiratory effort. We want to achieve, in addition to a good blood gas and safe lung distending pressures, an adequate level of respiratory effort. And this makes applying ventilation and sedation, somewhat more complicated. But if we can do it, then potentially we may be able to avoid both lung and diaphragm injury, improve outcomes, and improve a long-term functional status for survivors. Another exciting concept that many are working on is this idea of phrenic nerve stimulation. And the idea is that, okay, we might not be able to get the patient to breathe exactly the way that we want, but during periods when they're not breathing, if we can go in and stimulate the muscle exogenously with phrenic nerve stimulation, then potentially we can get the diaphragm to be active and avoid some of the complications of diaphragm inactivity. And this paper by Steve Reynolds and colleagues published some years ago demonstrated that phrenic nerve stimulation could actually prevent the development of diaphragm atrophy. And you see here that in comparison to controls, this was in a porcine model. Experimental animals that were not paced had a reduction in diaphragm cross-sectional area, this disuse atrophy, but cross-sectional area was relatively preserved in the paced animals. So that's quite an exciting proof of concept that we might be able to prevent atrophy with these techniques. Once the muscle injury is established, then potentially we may be able to rehabilitate the muscle with inspiratory muscle training techniques. And this systematic review that was published a few years ago now demonstrates that that inspiratory muscle training is associated with an increase in diaphragm strength and possibly in a shorter duration of mechanical ventilation. So I think this technique requires more study, but remains a promising intervention for patients with diaphragm weakness. All right, so to wrap up and summarize, I pressed my case that diaphragm weakness is very common. It prolongs mechanical ventilation and increases the risk of complications, that there's a variety of mechanisms by which mechanical ventilation can cause diaphragm weakness, and those mechanisms themselves seem to be associated with poor outcome. So it's possible that intervening on these mechanisms in a variety of ways could potentially accelerate liberation from the ventilator, enhance the probability of survival, and improve long-term functional status for patients who survive acute respiratory failure. So thank you very much. I'll be very happy to take your questions and comments and discussion.